This program aims to find solutions to your medical queries. It seeks answers to common health problems that have been hounding you. We will help you out in finding answers to your medical concerns. I'm Angel Jacob and this is MedTalk, your weekly on-air health consultation here on the Solar News Channel.
For years, surgery and the operating room have always been associated with pain. Those in the medical profession sought ways to eliminate or at least reduce the pain experienced during operations. Anesthesia is administered to patients so that they can be comfortable and possibly be even unaware of any pain during a medical procedure or surgery.
Well, it's a state of insensitivity to pain and to other sorts of sensation. So it's not only pain, but also touch, also all the sorts of sensation that a normal human is able to experience. You have the general, wherein the whole body is insensitive and the patient is totally asleep. And regional, wherein only a region of the body is insensitive to pain and other sensation.
What preparations are needed before one is administered anesthesia? What are the risks involved? What are the benefits and various options available? Find out the answers tonight on MedTalk.
Joining us tonight is Dr. Iluminada Butz Camagay, former president of the Philippine Society of Anesthesiologists, a pediatric and neuroanesthesiologist from the Makati Medical Center. Also joining us is Dr. Resty De Ocampo, an anesthesiologist with subspecialty on pain medicine, a member and former chairman of the Board of Medicine of the Professional Regulation Commission. You may join the discussion by calling our hotline at 548-4678. Good evening, doctors. Welcome to the show.
Good evening, Angel.
Good evening, Angel.
Anesthesia.
Yes.
You know, so when we hear the word anesthesia, there's a certain phobia that comes with it. Why is this so? Dr. De Ocampo?
Well, it's because of the fear of the unknown, and anesthesiology is poorly understood. There's a lot of explaining to do, and it's a dynamic specialty that has grown over the years. I hope we can debunk them tonight.
Yes, doctor, that's exactly what we're going to do tonight. So how can we debunk this phobia or this thinking that when anesthesiologist is administered, there's a certain uncomfortability or there's a certain fear that goes with it?
Well, we would like to debunk these phobias or irrational fears by letting our countrymen, our viewers, the common tao, know more about what we do. Because when one is ignorant, then the fears come in.
Anesthesia or anesthesiology is the science and study of anesthetic substances administered to patients for surgery or to take away pain.
Well, anesthesia, I think the whole state in the beginning, it's being able not to feel the pain.
Yes.
Okay, and the most common modality or way of taking away the pain is to take away this consciousness or the sense of pain. And in the beginning, you had gases that were administered and the patients breathed them so they wouldn't feel the surgery. But there are also ways of making patients not feel pain. If you have had a tooth extraction, an injection close to the source of the surgery can be done, or it could be away from the source of the surgery, but in the pathway of a big nerve that will bring the pain sensation to the brain.
And there are many types of giving anesthesia. First of all, it can be divided into one general anesthesia or regional anesthesia. When we say general anesthesia, it means a loss of consciousness. It means that impulses to the brain are blocked, and therefore you're not aware of the pain because they are blocked in the brain. However, the pain coming from the periphery or from, for instance, the extremities can be blocked also. The nerves can be blocked. So we call that a regional anesthesia because a region of the body has been blocked of pain sensibilities.
Okay, so you mentioned general anesthesia and regional. I understand there's a third.
Now, the
type.
regional anesthesia, it is possible not to lose consciousness and still not feel pain. If you remember, there are women or there are surgeries where they inject the anesthetic on the back,
Yes.
so that it can reach the big nerves coming from the spinal cord. Yet, whoever it is that's given that injection doesn't feel the pain, but they're awake. So you have women who deliver by cesarean section or normal delivery, they're awake, but they don't feel the pain.
However, there are patients who must be put under general anesthesia. And there are patients who might reject or refuse spinal anesthesia, and we honor that request by putting them under general anesthesia because a cesarean section can be done both ways, safely under general or under a regional type like spinal or epidural anesthesia.
Well,
However, we prefer to give them spinal or regional anesthesia.
Okay, we'll talk more about that, doctor, and the third type, which is local anesthesia. But we have a caller on the line.
Yeah.
Hi, Stephanie. Good evening.
Hello. Hi, good evening.
Hi, your question, please, for our doctors.
Yes, I have one question here because I'm actually due to give birth in 4 months. My question is, what are my possible options for pain and relief during the labor and delivery?
Okay, thanks, Stephanie.
Yes.
Dr. De Ocampo?
Well, you can have what they call a painless delivery, where the most popular is epidural anesthesia. We can give it at the start of labor, or sometimes it depends on the obstetricians. Sometimes the obstetrician wants their patient to have contractions, wants the baby to go down first before the mother is given an epidural or a spinal. But there are options. If the obstetrician opts or the patient opts to have a painless experience from start to finish, we can do that. We can give the epidural, thread a catheter into the epidural space and give the local anesthetic there to block the pain sensations, and the patient will have no pain during labor.
So half awake also.
Until delivery. The patient is awake.
Okay.
The patient has to be awake because with the epidural anesthesia, she has to bear down, and she can bear down to push that baby out. So it's a very specific or type of anesthesia where you block only as much. There's no what we call motor block because the patient has to have the muscle power for her to bear down and push that baby out.
Assuming this patient is having her a normal delivery.
Right.
Delivery.
Well, that can, if it so happens that the obstetrician decides on a cesarean section, then you can give a local anesthetic fitted for a cesarean section, meaning to say the concentration of the anesthetic is changed. Normally from a 0.125, we call it, or a 0.25 local anesthetic to a 0.5 local anesthetic that will block more impulses or more nerves.
Dr.
Yes.
Abutz, how does the anesthesiologist determine the amount of medicine or anesthesia to be administered to a patient?
First of all, it's a matter of matching. You match the patient, whether he's ill or not, you match it with the requirement for the procedure. There are some procedures which are more painful than others. Bone surgery is the most painful kind of surgery. And then you also match it with the competence of the anesthesiologist, if he has trained enough to be able to look at an array of methods and drugs that will be able to be applied to the patient and to the procedure that's to be done. So first of all, you have to be competent. You must have finished medicine, passed your board examinations, and then trained in a competent training program, pass your board examinations, because that way it's like having a menu of possibilities that you can apply to match the two procedures, the patient and the procedure.
It doesn't necessarily mean that if there's a procedure that requires general anesthesia, that patient will have general anesthesia, or can that patient still have local or
That's
regional?
where the competence comes through, because you cannot always have a decajon. All right, so there are some patients normally, let's say a child would have well, let's say an 18-year-old can have a tooth pulled out with local anesthesia. But if that 18-year-old is mentally challenged or is autistic, you cannot give a local anesthesia because it's entirely unfamiliar, and you cannot get their cooperation. So in most cases, it has to be a general anesthetic. And the anesthesiologist must be able to determine what drug will I give, how will I deliver it, and then how do I find out I'm able to take care of the pain and not too much for the patient either. And we do that with various what we call monitors. We watch the patient's level of consciousness, if they're going down. We watch if their breathing is going down, their heart function also goes down, and then also how much bleeding there is, if there is enough muscle relaxation, because you cannot have a tooth pulled if the jaw cannot be relaxed. So all of these come into the picture, and they have to be synthesized in the mind of a competent anesthesiologist. So I think that you have to be fairly bright to be an anesthesiologist.
And,
That's nice to hear. Well,
and we were talking about that earlier, no? Debunking the myth that the anesthesiologist just administers the anesthetic and then leaves.
No, never leaves. It's
Never
a
leaves.
breath to
Monitor,
breath,
yes.
heartbeat to heartbeat. That's why I said we don't even do Twitter. We don't even do
we
Facebook.
even have to accompany the patient from the operating room to the PACU or post-anesthesia care unit or recovery room and see to it that the patient is all right. Her vital signs are normal. She has no pain. She's comfortable. So she's stable. By the way, when she said...
Doctor, I don't mean to interrupt, but
Go ahead.
we have a caller on the line. We have
All
another
right.
caller on the line. We have Michael. Hi, Michael. Good evening.
Hi, good evening.
Hi, your question, please, for our doctors.
All right. Hi, Doc. My question will be, will anesthesia make me sick? And will there be complications and side effects?
Will it make... Thank you, Michael. Will anesthesia make him sick?
We hope not, because in the old days when we were using ether, anesthesia could really make you sick because you could vomit, you would have a headache. But with the newer anesthetic agents, now they don't make you sick unless you've been sick from the beginning. They make you wake up faster, and they make you fit enough to drive if you come out of it. But a competent anesthesiologist knows what to expect. If we expect that you're going to vomit, we expect all the dire scenarios you can imagine, but we prepare for that.
And in preparing for that, the patient should also be prepared mentally, physically, and emotionally. And we'll talk more about that when MedTalk returns.
Did you know that nitrous oxide, better known as laughing gas, is one of the oldest and most widely used anesthesia drugs in the world? The first time it was used as an anesthetic drug was in December 1844, when dentist Horace Wells, with the assistance of gardener Quincy Colton and John Mankey Riggs, straightened insensitivity to pain from a dental extraction.
We're back here on MedTalk, still talking about anesthesia. Dr. De Ocampo, before we cut to the break, you wanted to add something?
I wanted to add something about indications. The different types of anesthetics or anesthesia techniques have different indications. A type of surgery will have this type of technique indicated. For instance, in the elderly, studies would now show that regional anesthesia is more indicated, for instance, for hip surgery, for orthopedic surgery, something like that, instead of general anesthesia. By the way,
Doc.
no two anesthesiologists are alike in their,
Yes, but we are all united in fasting the patients as a preparation for anesthesia.
But our aim is always safety. The safest anesthesia for the patient, for the procedure.
Aside from fasting,
Yeah.
what are the other preparations that a patient must go through before being administered
Well,
the anesthetic?
I will elucidate on the fasting first because it's the most important one. You know, normally when we go to sleep and then some saliva drips down our throat when we are asleep, we wake up coughing because what should normally enter the lungs through the passages, air passages, is air. But if liquid comes in, then there is a protective reflex that will cough out liquid or any particulate matter that comes in. So in an anesthetized patient, the patient is more than asleep. She's more deeply asleep. Therefore, that protective reflex is absent. So if a patient shortly, maybe 2 hours or an hour before the anesthetic will be delivered, if he eats or drinks, kahit na tubig, I always tell them, kahit na tubig, nakamamatay. Because while it's sitting there in the stomach, the mind is relaxed, the stomach is also relaxed, so it stays there. It doesn't get propelled down to the end of the intestinal tract. So that's always available to come out as vomit. And when it comes out in the throat, it is very easy to go down the lungs and drown the lungs so that no air comes in, and the acid from the stomach can burn the lungs as well. So this is a very important preparation. So that's one. And then the second one is that we know if it's an elective anesthetic, we don't want the patients to have any colds, yung ubo, walang sipon. Because when the patients have respiratory tract infections, the air passages become swollen. So air cannot pass through freely, and that makes the subject of the anesthetic oxygen deprived.
Doctors, we have a question from
Yes.
Facebook. Is it possible for you not to wake up after being administered the anesthetic?
Oh yes, oh yes. That's why you have to be sure that the doctor who is giving you the anesthesia is capable, proficient, competent to give anesthesia.
How many hours after being administered the anesthesia, or how many hours after the surgery should a patient be able to wake up and to be able to be conscious
Immediately.
already? Immediately.
Immediately.
You can even wake the patient up during surgery.
Oh, why?
So we
Really?
have so much power.
Okay.
We put to sleep the patient
And you can wake the
paralyze him
patient up as well.
in one instant and wake him up the other.
Yeah, because there are
Yeah.
some surgical procedures where they want the patient to be awake because they want to test, for instance, on surgery of the spine. They have this wake-up test. They want to know if the hardware that they're putting on the spine is having an effect on the patient.
So you can speak to the patient well. Can you? Is that-
Give indications.
Indications.
Can you feel this? Can you feel your feet? And then squeeze my hand.
Just
Okay.
one
Yes,
last
doc.
thing.
Yes, go ahead.
No pun intended, but the operational word for patients before surgery is optimize the condition of the patient before surgery to make it safe. That's the objective. For instance, if the patient is dehydrated before surgery, that may be catastrophic if you don't replace the fluids that have been lost in the patient. So you optimize the condition of the patient before the patient goes into surgery. Now we can have the question.
Okay, thank you, doctor. Twitter, this time it's from Twitter. How soon can I drive after being given anesthesia?
Well, it depends on the procedure that was undertaken. It could be a diagnostic procedure which required an anesthetic, or it could be a minor surgical procedure where the anesthesia was given. By the way, I'd like to say that there may be minor or major surgeries, but there is no such thing as a minor anesthesia. All anesthesia is major, as in major.
Okay.
Anyway,
Okay. That's how major
General
it
na
is.
major pa.
major pa.
Okay.
But
Walang
if-
sergeant dito, walang
Wala.
private.
General na
General.
major pa. Okay.
But so anyway, if it's going to be a diagnostic procedure or a minor surgical procedure, this is usually done on an outpatient basis, also known as ambulatory surgery and ambulatory anesthesia. So we give a drug which will block the pain, but which will enable the patient to wake up immediately. In many cases, an inhalation anesthetic is the preferred anesthetic because every time, after we turn off the anesthetic, every time the patient exhales, he exhales the anesthetic as well. So the blood levels are very low, they wake up faster. Another modality where the patients wake up very fast with minimum vomiting, practically no vomiting, and a sense of well-being is propofol. This
What
is
is it?
this is the drug that was given to
Remember
Michael Jackson.
Michael Jackson, who was overdosed
Oh,
with
Yes,
propofol.
yes.
unfortunately, Michael Jackson did not have an anesthesiologist to administer it. But
Did
propofol
not
is
have
good because
Dr. Akamagay to anesthetize
Yes.
him.
so patients wake up very fast and they can drive. And before we discharge patients from the post-anesthesia care unit, we administer certain tests. For example, if the blood pressure and respirations have normalized, then we also ask them, can you move your legs? If ever, then we administer some tests. Can you hold my hand? Where is my nose? And then we keep, or use your finger, and I keep changing my finger positions, and so forth. So there's some neurological tests that we administer to make them what we would call
Alternate scoring system.
street fit to go to the street,
Okay.
Okay.
And in that Twitter question, fit to drive.
fit to drive.
Fit to drive. Do you know what, doctors, there's this myth.
Yeah.
Let's debunk this myth that if you're given anesthesia, in the long run, you'll become forgetful.
Well, let me
That's
answer
fair.
that.
Yes, Dr. Wood.
Because this is going to be a little long because we have a study here in the Philippines which we undertook in connection with psychologists, clinical psychologists, where they administered a battery of tests, memory tests, no? really scientific. Before the anesthetic was delivered, 1 week after, and 1 month after. We took away all the drugs. We did not give drugs that are known amnesics, or drugs which make you forget, such as dormicum, the benzodiazepines, Valium. Those are drugs, scopolamine. We took them all out. And then we just gave pure inhalation anesthetic, pure regional. And we found out that there was no loss of memory among all the patients we studied. By the way, this study won first prize in
Yeah,
the UP.
congratulations again.
Yes, and they are proposing that what is this, why is it that it's mostly pregnant women who delivered who have memory loss? Well, in the old days, they used to give this twilight anesthetic, which was Demerol or meperidine in combination with scopolamine. Scopolamine is a known amnesic, all right?
Hallucinatory drug too.
Yes. And then the other thing is that, why is it that it's the pregnant women? Then one would say that, oh, because after the baby is delivered, they have to do so many things, take care of another human being, so they become forgetful. But another theory that they have come up with is they found out that pregnant women secrete a hormone called oxytocin. This is the hormone that makes the uterus contract. Because if the uterus does not contract, the woman will bleed to death. So we augment oxytocin by giving intravenous oxytocin just to make the uterus contract after a woman delivers. Oxytocin has been known, studies have shown that oxytocin makes subjects forgetful. So this is one aspect. And if a patient is not deprived of oxygen, then there is really no loss of memory. So this study we undertook was between patients between ages 20 to 40. But when they are 50 or so in the senior citizen group, then there may be changes now because the nerve cells are fewer in number.
And you can't go back to the time when they
Yes.
gave birth and
Yes.
they attribute the memory loss
Yes,
to
to-
that
Could
experience.
be, yes. Senior citizen moment.
You can't refer back to that anymore. But you know what, doctors, we've run out of time.
Okay.
And
Thank
yes,
you.
but
Wow, it's,
it was fast, no?
yes.
But we'd like a final word from both of you doctors on you know, informing and educating our audience on the importance of getting an
Okay.
anesthetic before a procedure or
Ladies
before
first.
surgery.
Okay, ladies
Dr.
first.
Woods?
I would like to tell our audience that it is your right to ask questions. Ask your anesthesiologist what the risks are, what I need to do, and don't be afraid to ask questions because an honest anesthesiologist will tell you, I don't know, but I can find out. But first of all, the first thing to do is ask. And you shall be answered, hopefully, to your satisfaction.
And that's what we did tonight. Thank you very much, Dr. Woods,
And
Dr.
I will
De
not.
Campo.
And I will not. And it will be open, to you to tell you that October is the month, is anesthesiology month or anesthesiology week. The Philippine Society of Anesthesiologists is celebrating anesthesiology week during the third week of October. Actually, there is a World Anesthesia Day, which is celebrated or commemorated on October 16. To commemorate, by the way, that's very bad English, to commemorate the first the ether anesthesia, the first general anesthesia that was administered to a patient at the Massachusetts General Hospital in Boston, Massachusetts in 1846 by Dr. Crawford Long. And Dr. Crawford Long, by the way, is a dentist. So what I'd like to tell our audience is that number one, pain now is a right. You have the right to be free of pain. Pain has many dynamics or many sides. There's a spiritual, physical, etc. We're talking here of physical pain because some patients who have pain want to offer it to the Lord. That's fine. That's the spiritual dimension of pain. But for those with physical pain, you have a right to be free of that pain. And now there are pain specialists, pain management units and centers who can take care of your pain problems. And then I would like to emphasize also that anesthesia must be given safely. Our objective is always to have safe anesthesia. That can only be done if you have a capable anesthesiologist, a competent anesthesiologist who is vigilant, who will watch over you in the operating room. Thank you.
And thank you for, when we started, we wanted to debunk the myths of, the fear of the mention of the word anesthesia. And that's exactly what we did tonight. Thank you, Dr. Woods, and thank you,
Welcome.
Dr. De Ocampo.
It was a pleasure.
Thank you.
Thank you once again for joining us. See you again next Tuesday, 10 p.m. on MedTalk here on the Solar News Channel. This is Angel Jacob. Good night.